Welcome back. This is Dr. Nadim again. It's about time to continue together the case of Heba. Let me remind you that by the end of the first part, Heba was having a non-reactive, non-stress test and that she is now scheduled for an ultrasound assessment. Ultrasound assessment of fetal well-being includes assessment of fetal growth through biometric measures that are plotted on fetal growth charts, as well as the performance of a biophysical profile. You may have the opportunity to observe ultrasound assessment for fetal well-being during your clerkship activities today. It's becoming universal day-to-day practice in any maternity hospital. Biometric measurements are performed whenever there is any risk factor of abnormal fetal growth pattern. In that instance, we are plotting the measurements on specific growth charts in order to compare and to measure if they are below the 10th percentile. Plotting these measurements on standardized growth charts is essential, and it appears that the importance here of having reliable dates in order not to make a false negative or a false positive diagnosis of an abnormal growth pattern. Decreased amniotic fluid is an indirect marker of decreased glomerular filtration rate due to shunting of cardiac output away from the fetal kidney in response to chronic hypoxia. This will be discussed in more details whenever we are going to tackle the subject of intrauterine growth restriction. You need to know the components of the biophysical profile as described by Manning. There are actually 5 components in addition to the non-stress testing: fetal breathing movement, gross fetal body movement, fetal tone, fetal heart rate, and amniotic fluid volume. If these are actually fulfilling the normal criteria described by Manning, each of them is going to be given a score of 2. If in case of any abnormality, an abnormal score of 0 is going to be given. Just to explain to you the amniotic fluid index until you see it during your clerkship activities in the ultrasound unit, actually we are calculating it by making the sum of the deep vertical pockets of amniotic fluid in the 4 quadrants of the lady's abdomen. You are actually not required to know the details of the interpretation of the amniotic fluid index, but let's focus on Heba's biophysical profile. Heba scored 8 out of 10 with a decrease in the amniotic fluid volume. Her physician told her that she needs to perform an umbilical doppler velocimetry. The umbilical doppler velocimetry is a non-invasive technique aiming to assess the resistance to blood flow in the placenta. The umbilical cord doppler flow velocimetry is based on the characteristics of the systolic blood flow and the diastolic blood flow. The most common used index to quantify the flow velocity waveform is the systolic-diastolic ratio. As the peripheral resistance is increasing, diastolic flow decreases and may become absent or sometimes reversed, and the systolic-diastolic ratio are increasing. Reversed and systolic flow can be seen with severe cases of intrauterine growth restriction secondary to uteroplacental insufficiency and may suggest an impending fetal demise. Details of how different indices are calculated are not part of the undergraduate curriculum. However, some clarifying notions might be more elaborated during our face-to-face encounter, as well as during your visit to the fetal care unit during your clerkship activity session. It's worth noting that the machine is computing the resistivity index, the pulsatility index, and the SCD ratio. Changes in the middle cerebral artery waveforms are occurring coupled with the increased resistance to flow in the umbilical artery due to increased placental resistance. Vasodilatation occurs consistent with a head-sparing effect in cases of intrauterine hypoxia, with subsequent reduction of the resistivity index of the middle cerebral artery. Heber's Doppler waveforms were reassuring with a maintained good diastolic blood flow and no increase in the cerebral blood flow. Because Heba was complaining on several episodes of decreased fetal movements, she was scheduled on a weekly basis to perform non-stress testing, which were mostly reassuring. Her blood pressure did not exceed 140/90. She carried her pregnancy to term and was scheduled for elective cesarean section at the 37th week gestation after a non-reassuring CTG and a drop of the amniotic fluid down to 6. She gave birth to a healthy baby with an UPCR score of 5, 7, and 9. I hope that by the end of this session, you remember that reduced fetal movements may be the first symptom that hints to a risk factor leading to fetal compromise. That all clinicians need to be aware of the potential association of decreased fetal movements with some key risk factors of fetal growth retardation, small for gestational age and placental insufficiency, and congenital malformation. Clinical assessment of a woman with reduced fetal movements should include assessment of fetal size with the aim of detecting the small for gestational age fetuses. Women who are concerned about the reduced fetal movement should not wait until the next day for the assessment of the fetal well-being. After the fetal viability is confirmed using Doppler or using the penile stethoscope, and the history still confirming a decrease in the fetal movements, arrangement should be made for the woman to have a CTG if she is over 28 weeks of gestation. Ultrasound scan assessment should be undertaken as a part of the preliminary investigation for women with reduced fetal movements and are beyond the 28 weeks gestation if the perception of the reduction in the fetal movement persists despite a normal CTG, or if there are any additional risk factors for fetal growth restrictions or stillbirth. There may be a role for the selective use of biophysical profile in the management and investigation of reduced fetal movements. Umbilical Doppler studies, on the other hand, should not be used as a screening tool in the general population. At present, there appears to be a role for umbilical Doppler assessment in pregnancies complicated by growth restriction or pregnancy-associated hypertension or preeclampsia. Before I end, you may have noticed that this recorded lecture is missing an algorithm that helps you to make the decision making whenever you are faced with a case needing an elaborate assessment for fetal well-being. You'll be happy to develop such an algorithm in the face-to-face session and in the clinical decision-making session. Thank you very much.